Thank you so much. Okay, so for my warm-up, train and tragi. So transfusion-related alloimmune neutropenia. So seeing the neutrophil count tank after presumably a leukoagglutinating product has been transfused. So red flag, you want to report that because there may be co-components that might cause trolley in someone else. And tragi, transfusion-related acute gut injury, which is a very interesting spin on donor leukoagglutinin. So if you have a baby who's getting transfused through an umbilical vein, well, unlike venous blood or DVTs that end up in the first pass circulation of the lungs, venous blood goes to the lungs. If you're infusing through an umbilical vein, the first high surface area vascular bed that a leukoagglutinin is going to confront is the gut. So transfusion-related acute gut injury is the trolley equivalent of a gut, usually in a neonate who might be getting transfused through an umbilical vein. So again, these are all interesting spins on the hazards of theoretical residual donor leukoagglutinins in the blood supply. So all kind of tied to our care on preventing trolley. Okay, so with that, thank you so much again for this invitation. I'm not being sarcastic or anything. I'm saying this in the absolute most loving and sincere way. This is my favorite place to present. I love hemovigilance and I love working with all of you guys, and it is such an unbelievable honor. And the topic, I think our theme really came to us quickly when we were planning, the session, because this is a bumper crop year for improved blood safety. And so that, I don't think it's going to make us go extinct right away, but the landscape of what we see might be changing, and you guys are incredible at what you do in sensing, ascertaining things that are happening. So this is a pivotal point in our professional history together. And I wanted to talk about platelets as a prize-winning provocateur and explain why I'm using maybe that denigrating title for them, but end on a positive note with the promising progress that we have, as I'm sure everyone's been in implementation mode, getting ready for November 20th for those who are served by the Brampton area. Okay, so let me see if I can advance my slides. Okay, so I don't have any relevant disclosures with industry. My objectives are going to be fivefold. So I'm going to begin with the story of a person. I'm going to talk about a puzzle. So this is a diagnosis that I think many of us maybe don't consider, but maybe ought to, and maybe this makes the sign out of this particular case a little more complicated. So I'm very curious about how this audience would think of or integrate this possibility in the sign out. We're going to talk about platelets as a dual entity. I have a little picture of bubble tea because, you've got cells suspended in plasma, so it's a bit of a 2-for-1 product that way. The Ig Nobel Prize. So this is just to shine a light on the fact that this product is the most reactogenic of them all. So I'll just show what some of that evidence looks like, and the UHN experience to speak to that. And then, rounding out on the promising progress. So some thoughts and notes on pathogen reduction. So this young lady, not her initials, but I'll call her PJ. She had an acute respiratory platelet transfusion reaction. And she is a daughter and a sister and a wife and a survivor of breast cancer. So 2 years ago, went through it all, had combined modality therapy, and unfortunately had some cytogenetic fracture from her treatment. So she developed a BCR-ABL negative pre-B-ALL with a translocation T411, KMT2A mutated. So next is going through ALL therapy. She goes through the Dana-Farber Center protocol. Asparaginase, gets through it, doesn't have clots, goes into total remission, and to seal the deal, goes for a transplant. And in her leukemia care, had uneventful transfusion history, 3 red cells, 2 platelets, not too heavy. So now we see her, she's day 18 after this BMT. We use a convention for hybrid blood types. A TAO means she was born A and transplanted to O. She had a 10 out of 10 matched unrelated donor. This was a fully myeloablative protocol. She was young, tough enough for this. And she was coming out of her febrile neutropenia, and this was actually neutrophil engraftment day 1. But though her neutrophils were starting to come back, she had terrible grade 3 mucositis. And in the course of her BMT, had a little more blood product support than her leukemia care entailed. And so on this day, day 18, with her bleeding mucositis and at a platelet count of 3, she gets 2 consecutive doses of platelets. So the first one is at 10 in the morning. She has a beautiful increment. Her PRA was only 10% at baseline. And she gets her next platelet, also a very nice increment, gets up to 61. That's at 10 p.m. The latter platelet gets infused not too quickly, more than an hour, maybe 2. Obviously, both of these are irradiated, not end of shelf life. And before she gets the second platelet, she starts off with a fever, though she wasn't pre-medicated, which was interesting. She's quite tachycardic. She's dyspneic or tachypnic, and you can see in her vitals her rest rate is increasing in the hours beforehand, but she's on room air. And no one's poking her for an arterial blood gas because it's just tachypnea. So at completion of the second of the 2 platelets, 12 hours apart, her temperature goes down by itself. Again, no acetaminophen on the scene. Her blood pressure is quite high. And despite the fact that her Dana-Farber protocol had a cardiotoxic anthracycline, it was doxorubicin involving, she had a completely normal echo. She was still just as tachycardic, no dysrhythmia there, and that heart rate of 140 or so. Her rest rate was quite high, and she's desaturating. So she goes to 86% on room air. She's on non-rebreather mask, high FiO2, it gets to 100%. Now she's desatting further at 77%, so she needs intubation. She's intubated for less than 2 days. Her arterial blood gas shows that she's in ARDS, so her PF ratio was 174 on an FiO2 of 100. Her chest x-ray is clear ARDS. There's no PE on a CT. She has bronchoalveolar lavage, completely negative pan cultures, blood and urine. And this is her x-ray. So not really looking like circulatory overload. And again, that echo looks not overloaded, and she's diuretic non-responsive. So question 1, was this reaction, and you can pick as many choices as you want, was this a type 2 trolley? Was it technically just a TARDS, a transfusion associated ARDS? So she was already on a trajectory, and this is just the, ARDS level version of that. Is it a TAD? Is it idiopathic pneumonia syndrome? Is it something other than these 4 choices, or I just don't know? I love watching these bars because this was the exact same struggle that everyone around her bedside was facing. It was the sparring of ideas. So not otherwise specified. So a transfused ARDS. So not trolley, but just an ARDS that was inevitable, that happened to have had transfusion as its incidental co-marker. An ARDS that was happening irrespective of transfusion, maybe heated up a bit by it, but not deemed transfusion attributable per se. Okay, so I'm not going to give the answer yet because there's a little bit more to learn before we maybe change our minds. So the TACO criteria, we kind of went over what the updates in 2019 said, and this is just to remind ourselves what the diagnostic criteria are cassette-wise, how many of them and what. So respiratory distress and or pulmonary edema, that's clinical or radiologic or both. So you need one out of those 2 in that critical yellow band. And you need at least 1 more cassette to gain a total of 3 criteria. So cardiovascular system changes, fluid overload, or a natriuretic peptide surge. And her BNP did go up, but we didn't have a baseline by which to compare it. So if we look at these criteria, a number of people would say, hey, that's a home run TACO. Yeah. There was pulmonary edema. Her BP just shot right up. Her BNP got elevated. Another equally expert person is looking at this exact same criteria list and says no. Pulmonary edema without other specific causes, and maybe there are other specific causes here. Cardiovascular system changes. She's tachycardic, maybe she's distressed. How do we know that what happened to her hemodynamics aren't explained by an underlying condition? She was diuretic unresponsive, so the idea that she was fluid overloaded is contested. And again, we don't have the ability to compare her BNP pre-post because it didn't exist, and so we can't show that there's a 1.5 times elevation. Yeah, it's above the upper limit of normal. So this is just to show that two equally expert people may clash. Looking at the exact, it's like, how do people interpret scripture, right? Like two people have a completely different take on what this means. Now for trolley, same year, bumper crop year for respiratory insults. So acute onset hypoxemia, bilateral infiltrate, ruling out left atrial hypertension, or that's not the main contributor if it's there. So onset within 6 hours, no alternative ARDS risk factors. And neither leukoagglutinating antibodies and donors nor confirmation of a cognate relationship required. So if we look at this, this is also a home run. So is this a taco/trolley, the permission of the fusion state, or is it really one more than the other? Now, what's interesting about no alternative ARDS risk factors is that it doesn't list IPS, and she's in that neutrophil engraftment window. That particular entity shows up nowhere here, but indeed that is a capillary leak state. As the neutrophils come back into better levels and you've got a very insult-stimulated individual, you've got a lot of degranulation, arsenal, or payload that you can further create injury with. So it's not on the list. So this is the summary table from the trolley redefinition paper. And we're hovering between these three entities. Maybe not a definite trolley type 1 because she was tachypnic beforehand and it was getting worse, though she was normoxic on room air. So, we could say she was stable for the 12 hours beforehand. If you interpret the rest rate as within a reasonably stable range, maybe this is just underlying ARDS, or I can't rule out possible trolley or taco. She's meeting criteria for both. So I think we all struggled with this. And if all of us had this case, would we all be coding it differently or the same way? I feel like 2 TISS meetings ago, we had one war breakout and now we've got another one. And this quote by Leo Tolstoy really kind of stuck out at me, especially as I think about respiratory transfusion reactions as another kind of internal war. And what he says is, to us, their descendants who are not historians and are not carried away by the process of research and can therefore regard the event with unclouded common sense, an incalculable number of causes present themselves. The deeper we delve in search of these causes, the more of them we find. And each separate cause or whole series of causes appears to us equally valid in itself and equally false by its insignificance compared to the magnitude of the events and by its impotence, apart from the cooperation of all the other coincident causes to occasion the event. And that is respiratory transfusion reactions in geopolitics writ large. And so the tadpole study, which we wrapped up last year, was obsessed with this idea that bad luck doesn't protect you from more bad luck from happening. A lot of forces converge on the alveolus, and there can be a hydrostatic force, mere congestion. There may be permeability forces opening things up, inflammation, infection, allergy, and anaphylaxis working deep in the lung, high up in the airway. Many mechanical mechanisms for dyspnea, maybe hemolysis with its off-target effects, and obviously leukoagglutinating events. And how these all interact with each other may produce the perfect storm, and maybe each individual has their own quantum signature to how they get sick. So for the tadpole study, we involved the adult teaching hospitals at U of T. And again, this was a clinical laboratory deep dive, and we were getting information from CBS on the mode of production and the gender of the donor and so forth. And so we're still in analysis mode, but we enrolled 151 patients, and this lady was our first enrollee. We thought, my God, this is one way to anoint a study. In terms of some of her investigations, there was maybe a gained class 2 antibody. And, one of my favorite editorials of all time on trolley, and the definition came from Ted Workington right here in the room, on, this non-requirement for leukoagglutinating antibodies when we have so many entities that we describe by the demonstration of a laboratory mediator that is very much involved in the pathogenesis. So this puzzle, so idiopathic pneumonia syndrome, I wanted to say a few words about that. This is a very educated audience, and I think we're always teaching others that association is not causation, and this is a very important piece of scientific literacy that I think people want to beef up in schools to not permit catastrophic disinformation sequelae like what happened with the pandemic and people not really understanding things. Vaccine adverse outcomes and so forth. So this is to say that, sometimes there are confounders and we overascribe. And the classic joker example is, you have as many lighters as cigarettes on the person of a smoker. And you could conflate possessing a lighter in your pocket as the cause of lung cancer. And so one needs to be biologically intuitive to really unpack pathways and not just look for pure association, because those strengths can be pretty high. So when it comes to a person going through a BMT, obviously there's these times to neutrophil, platelet, and red cell engraftment. And while, we don't give granulocytes, at least not at UHN, we prop up the other cell lines before they engraft with the platelets and red cells respectively. And here she was on her 12th platelet transfusion. She had 4 red cell transfusions, all non-reactive until these last 2 doses of platelets. And so the question is this her engraftment syndrome, or is this the pile-on effect of something peculiar to one or both of these platelets at this time, or all of the above? Now, if you're in computers, IPS usually means intrusion prevention systems, very important for those of us trying to prevent cyber attacks and hacking and so forth. But if you're in BMT, this stands for idiopathic pneumonia syndrome. And this is sometimes conflated with or a part of engraftment syndromes. There's also an acronym PERDS, peri-engraftment respiratory distress syndrome, which is about a third of idiopathic pneumonia syndromes. This is a bit of a mess. There isn't a consensus conference definition of idiopathic pneumonia syndrome like there is for trolley or taco. And so you see a very messy literature and different diagnostic criteria, and they don't agree with each other. And someone might meet one set, but not the other. And so, we're not even really speaking the same language necessarily. But what this is a bad outcome that happens in people getting auto or allo stem cell transplants. If you're getting an allo, it's higher risk in fully ablative regimens like our young lady had. The median time to onset is 19 days, so she was right there. And at this moment of perineutrophil engraftment, there's a non-infectious fever, rash, pulmonary edema with infiltrates, hypoxemia, multi-system capillary leak that's giving you hypoalbuminemia, weight gain from edema, sometimes hepatic or renal dysfunction, diarrhea, encephalopathy. This is a non-cardiogenic, non-renal pulmonary edema. And boy, this list literally looks like our 2 biggest fears in transfusion medicine, GVHD and trolley combined, right? There are graphics on the role of CRP and it as an indicator of this possibly happening, and her level is like right here at the cusp of this particular timing between engraftment syndrome free people and people who are on the trajectory to getting it. It's got a T cell and humoral signature biology to it. There are numerous mouse models, very high case fatality rate. I mean, it almost might as well be GVHD or trolley. 70% will die within 3 weeks. And I'm very sad to say that she did pass away 25 days after this reaction. People use various anti-inflammatory steroids. etanercept block TNF and its excess. And so if we come back to, the idea of confounding association causation, is it the platelet transfusion requirement that comes from bone marrow transplantation that is just the rider, the passenger in this pathology, or is it a driver? Is it contributing? So is this just apparent association or a legitimate causation? And so one interesting paper looked at platelets within 3 days of the idiopathic pulmonary syndrome, and even after they adjusted for confounders and the administration of other transfusions, this still kind of stood out. So that was interesting. And so, now we look at this case and we don't know what to call it. I mean, I still don't know what to call it, but I get the sense, and I've seen this numerous times now, that I see something very trolley-like with platelet administration in BMT patients at exactly this window. And would this have happened without the platelet transfusion? Maybe, and maybe not so severe. And how do we report this if this is just a cofactor, but not the solitary imputable? So platelets, what is it that makes them the most reactogenic of products? Okay, so here's the next question. So my comfort level with platelets, and you could pick as many of these as you want, it's very high. They fly in fast. This is mostly plasma by volume. You don't have to cross-match these. No different from red cells, an equal opportunity offender, very low. I see lots of reactions with these, and I want them better policed. Increasing, my comfort's increasing with the new modifications coming in terms of pathogen reduction and PAS. Okay, so I think, CBS and all of us as a community are very happy with the new modifications coming. It's interesting how many people are low, comfortable, or not comfortable, or neutral. So I guess that's not unexpected. We have an interesting diversity. So coming from the TISS data themselves, so the last available online report for the amount of platelets given relative to other things and the representation of platelet-associated reactions among reactions due to other things, there's about a twofold inflation here. So platelets being more reactogenic, right? And when we looked at, so I just literally crunched this in the last few days. So 13 years of data at UHN, over 800,000 transfusions, 4,300 or so transfusion reaction sign-outs, 1,860 from platelets. This same calculation gives us about almost a threefold reactogenicity of platelets relative to our other products and red cells specifically. So why is that? I tell everyone platelets are a 2-for-1. So whereas red cells, when you spin them down, are still mostly, it's a squishy organ. It's mostly cells, right? Platelets, they're tiny cells. We know they're like 10 femtoliters compared to the 90 or so of a red cell. And, there's an order of magnitude less, so 3 by 10 to the 11 versus the 5 trillion red cells in a bag of erythrocytes. That amounts to basically a dusty fluff and suspended in mostly plasma. And so, you've got all the trappings and harms that are inherent to plasma, and then you have the biologic effects of the platelet cells themselves stored warm. And platelets can get knocked off too. So the cells themselves are vulnerable to the immune system of the recipient. They've got antigens that could be under attack in terms of refractoriness. But when we look at that enormous amount of plasma that they've been suspended in, all kinds of humors, so the specific antibodies that may be cognate with the recipient coming from the donor, as well as a lot of the non-specific pro-inflammatory stew that can be reactogenic in different ways. And so when you put these items next to each other, platelets overlap as a plasma and cellular component, and running down that middle column, every risk is essentially inflated. And of course, room temperature doesn't help compared to refrigeration or freezing in terms of stalling the release of these biologically active mediators. And in the Plato study, there was a 10% transfusion-related adverse event rate for platelets. And so that just goes to show that when there's prospectively, obsessively metered events, you know, we get to the truth of these numbers, and that's a pretty high rate. You know, I now quote a 1 to 10% reaction rate with every person I do consent with. I reassure them most of this is minor, but you know, just be ready for this 1 to 10% chance, and it's going to be the highest with your platelets if you're looking at a suite of things. Okay, so now, parochial prizes. This is to shine a light on some of the data that we see. This is the surprise I have. This is my pug Wolfie. You know, sometimes I feel this way when I look at our events. Not when I look at my dear sisters in hemovigilance. They make this all possible and you know, rewarding and mystical and exciting. And so I'm grateful to all of these dear people who help process what we see in all of the facilities that we have relationships with. And so when we look at Canada, and you know, some of these numbers were shared by Joanne earlier, UHN and its relationship with remote client sites has us covering, if we add up the population catchment of each of these locations, about half of Ontario. And so we've been looking at our site-by-site reaction rates over time since 2014, since we started developing these client-site relationships. And our stable reaction rates over time have been between 1 in 100 and 1 in 1,000. And so that's passive hemovigilance, right? Not 1 to 10%, but this is sort of how we're running year by year. And this, by the way, is very interesting because our reaction rate before the pandemic, during the pandemic, pre-vaccine, post-vaccine, all of the same. And so all of the people who say the blood got more dangerous due to vaccination, they just have to look at how steady these dot plots are over time. So when we look at UHN and my humble windowless offices over at Toronto General, our annual blood utilization looks like this. So we cast out about 40,000 red cells a year and about 10,000 platelets, so a ratio of about 4 to 1. And this is what our noise plot or our summons histogram looks like for day-to-day calls for transfusion reactions, requests to investigate suspected reactions. We implemented EPIC at that red line point, and that took a bit of time to get used to. And so we had a slight reduction in our reporting rate. What I'm not showing here is just how heavy our reporting is now this year in 2023. We have innumerable days where 3 to 4 reactions are happening per day, and it's something that I've never seen before. So anyway, this run into the implementation of PRPAS platelets is going to be very interesting to see now that we've got this very high volume reporting rate. So UHN data have about 3 to 5% of our unique recipients having a transfusion reaction every year. So that almost comes to that 1 to 10% range if you frame it not by reactions per product's release, but reactions by unique individuals. And 1 in 5 of these disturbances are complicated. They're really hard for us to figure out. They actually take quite a bit of time. Almost 15% have an escalation event, you know, a critical care team or an outpatient gets admitted or they go to the emerge. Half of them are not minor. And most of our severe events are cardiopulmonary, like PJ's was. And when we look at our platelets and versus our red cells, although platelets are about 15% of our components dispensed, they account for 50% of our transfusion reactions. So they're outsized in terms of their contribution. When we looked at, you know, quarter by quarter, you know, we had the received ratio of pooled to apheresis platelets of about 3 to 1. And no difference based on format of manufacture in terms of reaction rate, and very stable over time. And so platelets, as I said, are most reactogenic, and we have a pretty stable rate of a 1.5% risk of reporting. And when you know, Sunnybrook and UHN combined our data and looked at our FNHTR experience. Again, our platelets jumped out as more FNHTR-genic compared to red cells, so 0.25% versus 0.17%. So 1 in every 6 of our platelet reactions is a bona fide FNHTR. In terms of rank order, you know, allergic reactions would be our topmost type of reaction with platelets, followed by, for us at least, we deem it unrelated when we finish the case. Third would be FNHTR, and then after that, we've got things like tacos, TADS, and maybe some passive hemolysis or serologic event. Very rarely bacon, but this was a real bacon that happened at UHN that passed the visual inspection step, and were it not for this glom of pus, this whole thing might have been fatally infused into the lady. And anyway, the robot, the machine just was alarming the whole time, and the mechanical obstruction foiled the complete administration. So, our BMT patients and the clinicians who care for them are very wary of bacon as a risk, even though, it's in that 1 in 1,000 to 1 in 100,000 risk range, because these are the people who don't have neutrophils. And I'll tell you just 2 very quick stories about BMT patients where PRPAS platelets really are so appealing. And in this first case, nothing really bad happened, but it was just the annoyance of this lady who was before her BMT, who within 11 days had notifications or alerts on 2 of her platelets. One of them was a query babesia. And then 11 days later, the donor who she had her platelets from had erupted with shingles. And so we were just on the lookout to see if any of these infections might have been present in her. So this led to some extra testing. Now, we tend not to directly contact the patient and alarm them and say, hey, you might have gotten babesia and shingles from your last 2 platelets. But, in the background, we're testing for these things just to close the loop. This second case was fascinating. And this just blows the lottery institutions to pieces. This 69-year-old who, between his 11th and 38th week after his BMT for AML, had between 26 platelet dose sittings, 2 definite bacons, where both the product and the patient with the transfusion reaction grew the exact same germ. Not both of those 2 times. The first time, the definite bacon was an E. coli from a day 2 Buffy coat platelet, so before the bacti-alert result came back. And in the second instance, it was a day 6, and it was a coag negative staph that was bacti-alert negative. And so this was stupefying, because if this septic transfusion reaction rate is as low as 1 in 100,000 from all of this pre-release incubation, his capacity to have had 2 events in 27 sittings is 700 million times unluckier than chance alone. So anyway, obviously he and his wife are super happy about PRPAS. And so, in this last section, I'm going to say a little bit about promising progress. So our implementation preparations. Okay, so another question 3. This is the last of our 3 questions. So our experience with PRPAS platelets, and you can pick 1 or more, we've already implemented and things are already better, fewer reactions, people love them. We've already implemented, but things are the exact same, maybe not enough time to see a difference. Or we've already implemented and things are worse. I'm getting calls all the time about the photosensitizer concern. We're seeing more refractoriness. Or we're about to go live, we're not ready, or we're about to go live and we are ready. I'm very glad that no one's seeing anything worse, so that's good. Okay, so the most popular is we're about to go live. So a lot of us are in the same dark, we're in this eagerness phase, very anticipatory, and Monday's coming up very fast. So many of our sites have our memos, our staff MSBs and SBARs and whatnot. And I'm not going to steal the thunder of the next speakers on recapping what the double modifications are of these 2-for-1 products. But that is spelled out for our users just to remind them why we're even doing this. And so we took the CMAJ approach of the 5 most important things you need to know about these platelets coming up. And we've got a more detailed 3-pager with just something that fits in the window of your email on, what's happening. And, one of the concerns, with the bedside practitioners is EPIC going to work when we're scanning these things in, because we're not irradiating anymore? And if we don't have to do PVR, how does the system verify that it was appropriately modified? So, obviously, we would have irradiation for people who had that indication and PVR for people who are recurrent reactors despite lots of pre-medication. In the new era, those are going to be default features. And on top of that, the newfound feature of being germ-free. And so that's going to apply to our pooled platelet, sorrelin treated in apheresis, but not to our untreated apheresis in PAS. So, we're a little bit nervous about making sure that we don't have safety gaps here and this slipping out into someone who needs irradiation. So hopefully what we've organized and engineered saves us. But again, I want to celebrate the fact that this is a landmark year for transfusion safety. So, we've got SDP, we implemented that between the spring and Labor Day, and now we've got PRPAS platelets, and the only holdout, the only thing left is red cells. And so while we've got mitigations for these two yellow things, what we need to do next is to just maintain conservative use, because that's all we've got left. So what are we expecting? So this paper came out and showed that there was a significant reduction in platelet-associated transfusion reactions. And, I've re-summarized my table on, all the grungy sadness of platelets and shown the middle column, looking a lot better, looking better than the red cells now. And, with that, it raises the question of maybe, we could even consider stopping the pre-medication. So I don't know if our institution is culturally ready for that, but we did propose that in our MSB to the hospital, and we'll see what people do. Nothing's being forced. We're not taking pre-medications away, but it is an interesting natural experiment. And what I'll show here, just because it's a sample size limitation, though we're officially launching on Monday. Since February 28th, with shortage time redistributions, we have had some of these PRPAS platelets come to us prematurely, and it was great. We were incredibly grateful because A, someone who needed platelets could get them, and B, we could test ourselves for how ready we were. And we'd received 248 of these products so far, and we've had reactions with them. So 3 out of 249 had reactions, and that reaction rate so far is statistically not different from a prior pre-EPIC launch kind of higher reporting rate period that's been well analyzed. And when we looked at whether or not these were severe, 100% or 3 out of 3 were non-severe with the new products. But that wasn't true in the old days. So we had a lot more severe type reactions for the platelet transfusion reactions reported. So what I'm hoping, and maybe this is like the pre-medication literature, maybe pre-medications don't stop the reaction from happening, but maybe they just tamp down the severity. So I don't know what we'll see. I don't know if the numbers will show absolute amounts being different or just the quality or the nature of the reactions being different. And the other interesting thing to consider is the Weber effect. So whenever a new drug gets launched, and we especially saw this with the mRNA vaccine, people are all alert, right? Like people might be in a period of over-reporting concerns. And so it's possible that, we're waiting to see a signal of reaction reduction, but we see a big wave because we've shone such a light on this. And there's just so much, institutional awareness, and people are watching their patient in ways they might not have before. So we'll see, but I'm curious to see if we'll have a Weber effect. Interestingly, before, we launched and we were doing our in-services with different specialty groups, I was surprised to hear from our bone marrow transplant team some concerns on the use of the sorrelins. And it took quite a bit of reassurance, the fact that there's a compound absorption device and, the 300 nanogram per mil concentration goes down to 0.5. So it's virtually absent by the time it's done processing. So you never really know what concerns people are going to have until you do your roadshow for in-servicing. So I'm going to end here. The concluding gains or reflections, when a person with a transfusion-associated pulmonary edema happens, we still, in full humility, and even, with the tadpole construct that this lady had, we still don't know what exactly occurred, and maybe it was a blend of everything. So I would say, maybe IPS is a new diagnosis for you guys to consider. And is it a confounder versus a causation? We don't know. We know that platelets have been quite the nasty beast, very important, very life-saving for patients, but quite a price to pay in giving us business with reactions to follow. And so I think, with PRPAS platelets, I'm hoping that we see fewer reactions, and if platelets are contributing to IPS, maybe we'll see less of that too. And if we do, then that might implicate platelets as having been causal in retrospect. So, this might be interesting. And, again, how do we gate on this or follow this? Are we going to have a Weber effect? Are we going to see more platelet transfusion refractoriness? I know that that's been a concern. I mean, you've got 15% less platelets and a 30% lower increment per infusion sitting. And so just kinetically, you're going to have more people maybe suspicious of refractoriness and precipitating tests. So how are hospitals going to follow for whether or not there are immune or non-immune modes of platelet refractoriness with the use of this product? Certainly, if bacon risk is nearly eliminated, do we even have to send these reactions off to culture? We were just having a discussion about this yesterday. Does the micro lab want our spent PRPAS bags for culture if there's methoxysorolins in them, and it's like, because we tend not to send IVIG bottles for culture, so should we have that same comfort with this? So I'm not sure I know the answer to that. And again, maybe less pre-meds. So I just want to say, how fortunate we are. I think about this every day, and especially now with what's going on in the world, and that we have each other, and that we care about things, and that, while so much grief and tragedy is happening, we're in this mode of constantly looking and making things better. And I think we should be just so proud and happy to be doing that. And so I thank you for listening. And now we're going to open it up for questions.